Good afternoon. My name is Professor Xavier Griffin, and I'm really pleased to be able to present to you and thank you very much for the invitation to the Regional European Meeting for the Fragility Fracture Network. I'm going to be talking to you about how multidisciplinary co-management of patients with fragility hip fracture really does improve outcomes, both health-related quality of life and indeed mortality. So really, first up, I want to just say that I'm presenting this on behalf of a very large team of people who make up the collaboration in the UK called the White Study. And all of the data that I'm going to show you this afternoon will be coming from the White Study. It's a tremendous collaboration, and in fact, it's made up of four main groupings. The first is, of course, the Fragility Fracture Network, and we have a UK division for that. And everyone listening here today will be familiar with the FFN. We also have our Orthopedic Trauma Society, which have been great support throughout the period of time that we've been recruiting into the study and continue to do so going forwards. We do have quite a bit of funding coming in to support us in the work, and that's coming largely from the National Institute of Health Research for the Biomedical Research Centre in Oxford, and also for some of the sub-studies within White. And we couldn't get it done without our trials unit. So Oxford Clinical Trials Research Unit have been key to the delivery of this study. So what is the White Study? Well, here's the research question. Patients aged 60 years and over with a hip fracture. We use 60 because in the National Hip Fracture Database, the hip fracture database for England, Wales and Northern Ireland, 60 is used as the proxy for fragility. And we ask surgeons and orthogeriatricians and anaesthetists and physiotherapists and occupational therapists to follow standard UK treatment pathways. There's nothing unusual here. And we're looking at two linked outcomes: health-related quality of life, and we've used the Euroqual 5-dimension score for that. And that's really based upon work we've done previously with patients and experts to try and establish what the most important outcome is to patients. And they tell us it's quality of life. But of course, we're also interested in mortality, which is reasonably easy to measure. It's a very hard outcome, it's unarguable, and we can collect it for everybody. Now, it comes with a little bit of a health warning, what I'm going to present to you. It's not fully peer-reviewed, and it's not yet been published. The preceding work that's established the model for the data has just been published in the Bone and Joint Journal. It's free to access, and you'll be able to find that online if you look for White. But we haven't published the results yet, but they're currently under consideration in the same journal. Now, before we get into the weeds of what we found and the exciting results that we've got, I think it's important that we just revisit the Euroqual 5-dimension score and just be clear as to exactly what our findings mean in regard to that score. So the EQ5D has 5 questions, and we've used the 5L, which means that there's 5 possible responses, 5 levels for each question. And that generates 25 different responses, which are translated into a single linear scale, which is a preference-based scale. And we've used a UK population preference data set to do that. And ultimately, we end up with a scale that goes approximately from minus 0.6 all the way through to 1. Minus 0.6 is the worst possible score you could get using EQ5D. 0 is a score that is equivalent to death. So all the negative scores are, in theory, worse than being alive, or worse than being dead, excuse me. And 1 is perfect health. Because death is common in hip fracture studies, we need to think about how we handle death in our analyses so that we don't introduce bias. And we have chosen to take Euroqual's recommended approach, which is to impute or add 0 when we know a patient has died, because that is how Euroqual is designed. And a clinically important change is probably in the order of 0.05 or as an upper limit, 0.075. So anything bigger than 0.05 is probably a small to moderate effect. Anything bigger than 0.075 is definitely a real effect and is worth chasing. It means real patient benefit. So we have 6,000 complete data sets. That means we've got 6,000 participants who've given us baseline data and 4-month data. And we closed the data set at that point. In order to do so, we had to collect 8,673 patients. And that took us a few years, as you can see, from May through April 14 to 17. And we had to do it with 21 hospitals who are our partners. And that's where the white team really came to the fore. We couldn't have done it without all our collaborators across those hospitals. So how well do we represent the UK? Well, as I said, we're sort of nested within the National Hip Fracture Database in some sense. So it's not surprising to see England, Wales, and Northern Ireland represented. And we've got a good geographical distribution. So are the people in the data set similar to the types of hip fracture patients that you come across in your practice? Well, let's have a look. We've got tables here. They're a little bit busy, but we can zoom in and I can show you that the sex of the patients here is approximately a 1/3, 2/3 split, male to female. The number of people in plus and below 80 years of age is, as you'd expect, about a 1/3, 2/3 split. And the mean age is 83 years, as we'd expect. If we look across here, ASA score distribution, these are frail patients. And they come from a mixture of their own home and some sort of supported accommodation. So in essence, they look very much like our local registry, which is the National Hip Fracture Database, and they're very reflective of that. I don't think there's a big selection bias in the white sample. So do we believe the data when we look at it across all of the data set? Well, I think we do. And here's my justification. So here's a plot. Here's all the hospitals down the side. Each row is a hospital. And you can see the numbers. Some hospitals provided more patients than others, as one would expect. And here's the adjusted health-related quality of life, or EQ5D score, 0. And this is at baseline. And we can see that these patients are not in perfect health. They're at about a 0.7, give or take, in their pre-fracture status. And when you adjust for their age, for their sex, for their cognitive impairment, and for their baseline mobility, you find that all the patients look very similar in all the different hospitals. And that's probably as we'd expect. When you account for important confounders, actually much of the variation falls away. So I think the data that we're collecting probably is pretty reflective of how patients really experience their quality of life. And do the data look plausible clinically? Well, this is a little bit of a complicated plot, but basically we've got 3 plots here: intracapsular, trochanteric, and subtrochanteric fractures, because they're all treated slightly differently. Again, we can see this line here in the center of the slides is the line of baseline quality of life, which is in the ballpark of 0.7. And then we've got various different treatment options down the side. Now, some treatment options are very unusual. So, for example, intracapsular fractures are very infrequently treated with an intramedullary nail, so we don't see much data there. But what we can say is that the population receiving total hip replacements here have a much higher quality of life at baseline than the population of patients receiving hemiarthroplasty. And that is probably as we would expect clinically. When we look at trochanteric fractures, there's not a lot of difference between people receiving a nail and people receiving a sliding hip screw. And when we look at subtrochanteric fractures, we're seeing that actually the bulk of people are receiving intramedullary nails. And so I propose that the data are concordant with what we'd expect in our clinical practice. And these are just checks that we've been doing to make sure we've not been collecting data incorrectly in some way or generating a bias. So what do we do with the team? Well, we sat down and we worked out what the questions were that we were interested in answering now that we had all of these data. One of the things that's very important in the UK is payment by results, or better known here as best practice tariff. We currently have 7 best practice tariff criteria. I won't read them out, but they're there. You can read them yourselves. And given that we're interested today talking about multidisciplinary care, you can see that actually they're very focused on multidisciplinary care in many ways. There's an element of everybody's practice embedded in there. Now, you need to hold in your minds what those numbers mean, because I'll be testing you later on. Just out of interest, though, multidisciplinary rehab led by a geriatrician and admission under a joint protocol is being done very well in the UK at the moment, and more than 90% of participants in the data set were assessed in those ways. So let's have a look. What do the results show us? Well, we have an unadjusted and an adjusted analysis. We adjusted for those same variables that we talked about earlier on. So perhaps focus on the right-hand slide here, the adjusted analysis. And what you can see is the different criteria down the vertical axis, criteria 1 to 7. That's why I said you had to remember the names of the criteria and what they meant, but we'll revisit that. And then we have the effect on EQ5D at 4 months. So this analysis is showing us whether EQ5D has got better or got worse compared to baseline if you did or did not achieve the BPT. So we're looking at a difference in health-related quality of life. The little red asterisk shows us when we have statistically significant effects. And remember, I said a small to moderate effect might be in the 0.05, and a large and easily appreciable effect would be 0.075. So you can see that we are at the lower end for each one of the criteria taken separately. But if you create a model where you combine numbers 2, 6, and 7 together, and you say for those patients that received treatment which included criteria 2, 6, and 7 as part of their treatment, then they had a 0.096 improvement in their health-related quality of life compared with those people that didn't. And in those cases, you can expect that to be easily appreciable by the patients. It's much in excess of 0.075, the upper limit of the clinically important difference. And it's probably the same as developing something like an acute psychotic episode. Patients report a similar quality of life impact. So that's a major life improvement we're able to deliver. So remember those 2, 6, and 7. Now, if we revisit what the best practice is, we can see that joint care with geriatricians or elderly care and orthopedic surgeons, fracture prevention with our rheumatology colleagues with falls and bone health assessments and treatment, and the pre-op and post-op delirium assessment, normally done by the geriatricians team, or certainly under the direction of the geriatricians team, and an interest in their medical and wider rehabilitation. Take all those 3 things together and you're able to create a really fundamental improvement in patients' quality of life. That's never been published before. It's never been reported before. It's what we've all believed, but I think we've now demonstrated it absolutely. Now, we talked about death. Death actually, when we did the models, didn't show us anything very interesting. What we found was people that were less fit, less mobile, more cognitively impaired, had higher mortality. And we were unable to really find a difference with those criteria. But what we did delve into is the commonly conceived problem of death as a consequence of delaying surgery. And what you can see here is that the number of deaths are in this column, and these are either patients that had no delay, which were the bulk, patients had a medical delay, or patients that had an administrative delay, i.e. we would have done them today, but we ran out of theatre space, etc. And you can see that the proportion of the deaths accountable, 12% for no delay, 21% mortality rate if you had a medical delay, and a 10% mortality rate, very similar to no delay. And when you run the stats on that, as it were, you can find that that's also true for health-related quality of life. And there's really a very significant difference between those people who are delayed for administrative reasons compared to medical reasons. What this is telling us is that the decision to delay for administrative reasons, such as I don't have a surgeon to do a total hip replacement for you today, but I do tomorrow, probably doesn't have an impact on quality of life or death. But if you are a patient that has to have a delay for a remedial clinical medical problem, then that's probably just a label of you being more unwell in general, and you have a higher mortality and a lower health-related quality of life. I want to take the opportunity once again to say thank you to the wider team, the excellent white team that have delivered this methodology, the statistics, the sort of gusto of doing the team, the patients that have contributed their data, and the sites, both the research staff and the clinical teams that have collected all of these information to bring together. Thank you. We wouldn't have been able to do it and present this to everybody without you. These are the top best 21 hospitals in the country, as far as I'm concerned. They are the white centers. Now, every time I present this, it's ever so slightly out of date. So if you're not seeing your name on that slide, it's because you weren't recruiting between 2014 and 2017, but you are now. And so on our next set of slides, you'll be in the best 28 hospitals in the country. Thank you very much, and look forward to any questions.